Key points are history of home delivery, untrained birth attendant, manual removal of placenta, history of fever with lower abdominal pain and foul smelling discharge, on examination uterus just above the pubic symphysis even after the 3 weeks, that is subinvolution. Ray CRP USG finding is showing RPOC. So your provisional diagnosis will be postpartum endometritis with RPOC because of high grade fever and foul smelling vaginal discharge, that is a classical sign of infection. Uterine tenderness and subinvolution suggestive of endometritis. USG is showing fluid collection and heterogeneous endometrium pointing towards the RPOC. History of home delivery by an untrained birth attendant without proper asepsis. Now the second question, what is your plan for managing this patient? So first one, immediate management and then specific management. Immediate management is you have to admit the patient, monitor the vitals closely, give IV fluids and resuscitation if signs of sepsis or hypertension is there. Broad spectrum antibiotics to be given, ampicillin plus gentamicin and metronidazole, that is a standard triple therapy for endometritis. Antipyretics and analgesics for fever and pain relief. Specific management includes suction evacuation under antibiotic cover for RPOC as evidenced by ultrasound, and sending endometrial tissue for culture sensitivity. Transfuse packed RBC if HB drop further or if there are any signs of hemodynamic instability. Then how will you differentiate between the postpartum endometritis and pelvic abscess? So endometritis is usually occurs during the early postpartum period, while pelvic abscess occur during late postpartum period. Endometritis is due to ascending infection from genital tract, usually the polymicrobial infection, and is associated with risk factors, prolonged labor, multiple vaginal examinations, manual removal of placenta, PROM, home delivery without asepsis. While pelvic abscess is due to unresolved endometritis or infected hematoma. Seeing the classical clinical features, fever, lower abdominal pain and foul smelling discharge. This foul smelling discharge is associated with the uterine tenderness, subinvolution. And here in pelvic abscess, there is a persistently high fever despite of the antibiotics, but the vaginal discharge is minimal or absent, and there is a severe localized pelvic pain with guarding and rigidity, which is a sign of peritonitis. In the USG in endometritis showing the heterogeneous endometrium RPOC, no clear fluid collection outside the uterus, but USG in the pelvic abscess is showing well-defined fluid collection with possible septations. Okay, possible septation. IV antibiotics initially. First, if we will see the management of endometritis, broad spectrum IV antibiotics we have to give, followed by evacuation if needed. But in the pelvic abscess, IV antibiotic initially similar to the endometritis, followed by the evacuation, that is USG or CT guided drainage or surgical drainage if needed. What are the risk factors for developing postpartum endometritis? So PROM, which is for more than 18 hours, prolonged labor more than 24 hours, multiple vaginal examination during labor, manual removal of placenta, home delivery or delivery in an unsterile environment, retained product of conception, anemia and poor nutritional status. How will you prevent this condition for future deliveries? So, by taking the strict aseptic precautions during delivery, active management of third stage of labor, ensure the complete placental delivery and inspect for the completeness. Prophylactic antibiotics in case of prolonged rupture of membrane or labor. Educate on institutional delivery and the importance of the skilled birth attendants. Close postpartum follow-up for early signs of infection. What complications can arise if condition is not treated properly or promptly? So this is sepsis or septic shock, pelvic abscess formation, peritonitis, secondary postpartum hemorrhage due to retained product of conception, chronic pelvic pain and adhesions, infertility due to Asherman syndrome, intrauterine synapse formation. Thank you. Stay tuned for more lectures.